Good morning, class. I wanted to talk to you today about lesson 4. We're going to be talking about mood disorders, specifically anxiety and depression, and then we're going to finish up with substance use disorder. So if you start with anxiety, which is chapter 9, your book gives you the definition of anxiety, which you can read there, and what free-floating anxiety is. That's when they're unable to connect a stimulus. They don't know what's causing the anxiety within them. And a lot of people have that free-floating anxiety. There are other things that you may get to understand in that people have automatic relief behaviors, things that they do unconsciously that are aimed at relieving that anxiety. And if you can think of some of the things maybe you do, whether it's tapping your foot or clicking your pen or clenching your jaw, those are some of those autonomic or automatic relief behaviors that we talk about. Anxiety disorder is uncontrolled anxiety that leads to impairment, social, personal, and work functioning. The first anxiety disorder that's discussed in your book is generalized anxiety, and this is the most common anxiety disorder that we have in the United States. This is when somebody experiences increased anxiety and worry about various situations on most days, and it lasts at least 6 months. And they have difficulty controlling anxiety, so it interferes with their daily life. They have considerable discomfort, lack of concentration, and then the impaired ability to function, whether or not they try to use some maladaptive coping, such as substance uses, or develop some kind of medical illness as a result of that. Some signs and symptoms of generalized anxiety. It is excessive worry and anxiety plus at least 3 of the following: restlessness, irritability, muscle tension, difficulty falling and staying asleep, and fatigue. And it can also have some somatic symptoms such as chest pain, hyperventilation, headaches, tremors, increased urinary frequency, GI disturbances. If you look at the incidence and etiology, that's listed on page 119. Most people who have this have had some kind of anxiety most of their lives, but often don't really look for treatment until they're in their mid-30s. About gender ratio, female to male, it's about 3 to 2, and 3% of adults in the U.S. Usually people who have this have a pre-existing or coexisting diagnosis of depression as well. The next anxiety disorder is that of panic disorder, recurrent unexpected panic attacks. It's basically an intense feeling of fear and terror that can come on suddenly. There's a whole list of signs and symptoms that are listed in the boxes on page 120. There's one box for the generalized anxiety, and then box 9.2 is for the panic disorder. Just know that it can be acute or uncued panic attack. Acute one is where you can tell what the trigger is. You know what the trigger is that brings on that panic attack. Whereas the uncued, they don't know. Oftentimes, people with panic disorders tend to develop what we call agoraphobia, which is the avoidance of specific places and situations that could cause the panic attack. And oftentimes, these are everyday circumstances, so it leads that person to become more homebound, leading to unemployment, not going to school, and those kinds of things. So agoraphobia often is an end result of the panic disorder because they're just trying to avoid having another attack. Then we talk about the specific phobias, and this is on page 121. All of us probably have had a specific phobia at a certain time. There's a whole list on box 9.3 on some of the specific phobias. Some of you may have a specific fear of spiders, arachnophobia. fear of blood, hematophobia, the fear of heights, acrophobia. That's kind of one of mine. Or being in an enclosed space. So look over those and see if you have one of those. The signs and symptoms of a specific phobia are listed there in box 9.4. Basically, it's an irrational fear of an object or a situation, and it's mainly when you're in contact or having to deal with that situation. You may have loss of control, fainting, or a panic, and you may avoid situations where you would have to interact with that situation or object. Oftentimes we know it's irrational, but you can't seem to help it. Other people develop that a specific phobia because they've had some kind of trauma. Like if you have a fear of water and you had a near drowning situation in childhood, that kind of makes sense. They go hand in hand. So that can be some of the issues there as well. And then we have the social anxiety disorder, which is also called social phobia, and that's excessive fear of any social situation in which embarrassment is a possibility. There's often discomfort at being watched or feeling like you're being judged by others. And this one oftentimes develops with an anticipatory anxiety. You anticipate well in advance, maybe like you have to do a speech in speech class and you have this anxiety ahead of time about that situation. Signs and symptoms for social phobia are listed in box 9.5 there on page 123. And then post-traumatic stress disorder. I'm going to have you watch a video on that where some people are preferring to call it post-traumatic stress injury because we often feel that you can recover from this. But it's a response to a situation involving, that may involve an actual death or threat of severe injury. So a lot of times people think of PTSD with our vets who've experienced war, but it can be anybody. The video I'm showing you today is for first responders. It can be somebody who's experienced a personal trauma, an attack, mugging, a rape, that kind of thing as well. The one thing that we notice about PTSD is people will often have flashbacks, a reliving of the event. So be aware that that's one thing that we tend to see. There's oftentimes increased anxiety and maybe guilt related to an event as well. And then emotional numbing, which is on page 124. People will, people, activities, or places that may be connected to the situation are avoided as a result of PTSD. And that results in that emotional numbing. There's an inability to concentrate, impaired social or work functioning. There may be some disassociation and depersonalization if possible, especially for a specific trauma that they've experienced themselves. They may try to depersonalize outside of their body from that. Box 9.6 on page 124 are the signs and symptoms. Just remember, oftentimes it's like this hypervigilance, easily startled, mental rerun, insomnia. It talks about the watchfulness, irritability, and aggressiveness. Our vets, I used to show a documentary about PTSD on some of our veterans, and many of them talked about how they had that adrenaline rush, that fight or flight response while they were at war, and they got used to that. Their body got used to sending that. But when they got home, there wasn't that need for that anymore, but their body and their mind hadn't adjusted to that. So any slight noise or anything would get them right back to where they were fighting, maybe in Iraq or Iran or Vietnam. all over again. And so that's that hard stance that they have to do, is leaving that behind and trying to deal with civilian life. The video I have you watch today with first responders, they talk about how difficult it is to deal with trauma day in and day out, and they can't leave it. It's where they live, and it's their job, and it's year after year after year. And so a cumulative effect can also be an issue. Some of the Just for Facts on page 124 and the Mind Jogger, look over that. See if you can answer that question. Knowing anybody can have it. You don't have to be a part of a national disaster or a mass shooting. But the people who experience those obviously may develop PTSD as a result. But if you've had some significant trauma, I watched a video on a woman who her house was torn apart by an earthquake in California, and then like 2 years later, right after they got that house rebuilt, then a plane crashed into her house. And so she developed PTSD because of the personal trauma associated with her home being destroyed. And she could hear the plane coming and thought it was getting louder and louder and louder. So every time now that she hears a plane, it brings back that fear of the plane going to crash into her home. The next anxiety disorder is obsessive compulsive. Know the difference between obsessions and compulsions. Obsessions are the unwanted thoughts or images that cause anxiety, and the compulsions are the repetitive behaviors that people do to try and relieve that anxiety. Know that for obsessive compulsive behavior, for diagnosis, because a lot of people say, I have OCD about such and such. Well, to actually have the disorder, you have to have significant decline in functioning with actions consuming greater than an hour per day. So these compulsions need to take up at least an hour or more per day. You would have invasive, inappropriate thoughts commonly related to either sexuality, violence, illness, death, or contamination. I used to show a video of a man who had OCD, and his main issue was that he was worried about causing harm to others. So the germs that he constantly washed his hands from, he was worried not necessarily for himself, but that he would pass on a germ to somebody else. I'm trying to think how he would be coping in this pandemic. That would probably really cause some issues for him. But also, if he would be driving down the road and he would hit a bump in the road, he would be thinking, even though he saw maybe it was a stick in his windshield, as he went over it, he thought, maybe I hit a small child. And he would have to stop and check or drive around the block and make sure. But he said it got to the point where driving around the block one time wasn't enough. He had to drive around 10 times just to make sure that he didn't hit a small child. And then he had to actually get out and look under his car to make sure he wasn't dragging this child. All of those unwanted thoughts can be very disruptive and very disturbing and make it very hard to function. He had to give up driving for multiple years until he was able to get therapy. Now, therapy for specific phobia like heights or for OCD tends to be behavioral therapy, where you're kind of exposed to the situation that causes you anxiety, but you realize for OCD, we expose them to that anxiety, but we do not allow them to do the compulsions, to do the ritualistic behaviors, and realize that things are still okay. It's kind of hard to go through that therapy, but after a while, they do tend to develop some coping mechanisms related to that. And then the specific phobia is similar, whereas you're exposed to heights over and over again and realize you don't die. That helps to calm that phobia down. Of course, we do other things. If you have a really bad case of OCD, you want to have some medication such as an SSRI, which can help. So treatment for anxiety disorders are listed on page 127. Of course, there's antidepressants. These are SSRIs. SSRIs are medications that we often use, that people can take on a daily basis. Benzodiazepines help for an immediate situation, but you don't want to be on those long term. They can have addictive type problems. And then note on page 127 talks about using propranolol, which is a beta blocker. Is good for heightened anxiety and social phobia, such as stage fright. If you're having stage fright before you go on stage, that medication is helps with that. Some other agents that are helpful are anticonvulsive medications, such as gabapentin as well. So take a look at that. And then look at the nursing diagnosis and nursing interventions. Then we move on to mood disorders. In chapter 10, page 137, know what a mood is. Know the definition of affect. That's that facial expression. Usually our affect corresponds with our mood, but sometimes with people with some mental health disorders, their affect isn't corresponding with their mood. Euphoria is an excessive feeling of happiness, and we think of that sometimes with some of our people in their manic phases of a bipolar situation. Mania is frenzied, unstable mood, out of control, or out of touch with reality. So the first mood disorder we talk about is depression. Major depressive disorder is when you experience depressed mood or loss of interest in activities most days of each day for 2 weeks. You can have single or recurrent episodes. It's usually significant, persistent, and severe. Signs and symptoms: hopelessness, guilt, melancholy, self-blame, fatigue, appetite loss, weight changes, decreased libido, crying episodes, irritability, anxiety, excessive worry, increased somatic symptoms, lack of concentration, difficulty making decisions, and anhedonia. Know the definitions of anergia and anhedonia on page 138. Anergia is marked decrease in energy level, and anhedonia, the lack of pleasure in things that they previously had pleasure from. And those are all typical signs and symptoms of major depressive disorder. The incidence and etiology: approximately over 25% of the population will experience depression in their lifetime. Episodes may develop over days, weeks, and last for months. And there's different theories on what causes depression. The main one that we tend to think of is the deficit, functional deficit of the neurotransmitters, specifically serotonin. So knowing that is one of the bases, usually a brain chemistry issue. There can be a genetic issue if it runs in your family. They're looking at that. There's side effects from medications and use of substances that can lead to depression, and then some psychosocial factors such as job loss, deterioration of a marriage, loss of a spouse, that kind of thing can cause a depression as well. Persistent depressive disorder is called dysthymia, and it's a recurrent state of depression that's greater than 2 years. It's not quite as significant depression as major depressive disorder. These people sometimes can still function in their daily activities, but they have a lifetime struggle of depressive symptoms, and often develop this negativism, learned sense of helplessness. And they will use escapes such as substances and spending sprees, or maybe sexual promiscuity, to try and make them feel better. Sleep difficulties, change in eating habits, and fatigue. So box 10.2 on page 140 are the signs and symptoms of dysthymia. And then we get into the bipolar related disorders. This is when you have brain dysfunction causing abnormal, erratic shifts in mood, energy, functional ability. We often tend to think this does have a genetic factor. If you have a relative who is bipolar, you have a higher risk for developing it. You can have, if you look on page 140, it gives the definition of what labile means. This is, it says the rapid shifts in mood in a short period of time are referred to as labile, or alternating from euphoria to dysphoria and irritability. In the DSM-5, the criteria for bipolar disorder, the mood change must be accompanied by persistently increased activity or energy levels that are obvious to those observing the person. So the other definition in that part I want you to look at is rapid cycling. When somebody has 4 or more mood shifts within a year, that's called rapid cycling. Basically, the signs and symptoms of bipolar 1, bipolar 2 are on box 10.3 on page 141. So know the signs and symptoms, and I would try to get to know what is the difference between bipolar 1, bipolar 2. Know what hypomania is, grandiosity, inflated self-esteem, knowing that people may feel persecuted, and if they have some psychotic features, may have clang associations, which is their speech may be rhyming, and that's really interesting when you hear somebody do that. May have no connected meaning, but your book is an example. Hare is bear, and bear is scare, scare is fair, fair is there, you are a pair. I saw somebody doing the clanging in person, and it's amazing that the brain is working that way, because it's hard for me to come up with rhyming words fast like that, but they were just rattling them off. And then look on page 142, it talks about cyclothymic disorder. This is a chronic mood disturbance, fluctuating periods of hypomanic symptoms and periods of depression. Basically, this is not super severe mood fluctuations, they're more mild mood fluctuations. So you have recurrent periods of hypomania and dysthymia. Remember, dysthymia is not quite as severe depression as major depression, and hypomania is not quite severe mania as you see in bipolar. So you have the hypomania and the dysthymia together, and you have cyclothymia. Signs and symptoms are at the bottom of page 142, box 10.4. So the treatment, of course, antidepressants. You need to know your medications for this lesson. Your next test is going to be a unit test, and I'm going to tell you there's going to be a lot of medication questions on that. So knowing the different types of antidepressants, what are MAOIs, and knowing box 10.5 that there are foods and drugs that you have to avoid if you're on an MAOI, because it can lead to a hypertensive crisis, is really important to know. Knowing what the SSRIs are, knowing that there's SNRIs, and then tricyclic antidepressants. So get to know them. Today you're going to be reading an article on antidepressants and answering some quiz questions related to that. So that's part of your class grade for today. The rest of your chapter goes through the nursing process for mood disorders and gives you some other information on medications. So you have antidepressant medications on page 145, and then on 148 you have some other mood stabilizing drugs, because obviously with your med research you did last week, you know that we use anticonvulsants, we use some other types of medications to help with stabilization of mood. So get to know that. And then last but not least, I want to talk about chapter 15 in your book, Substance Use Disorder. Now I'm going to have you do a paper today on substance use disorder. Chapter 15 starts on page 228, basically. Know what a substance is, what is substance abuse, the cravings a person experiences, and the definition of addiction and tolerance. The phases of substance dependency, knowing what it starts on page 229. Phase 1, somebody begins with the first use. They experience that euphoria or that high, and it's a temporary escape. Phase 2, the user experiences hangover effects and starts to feel guilty related to some of their behaviors. Phase 3, it's a dependent lifestyle with periods in which control over the substance use is lost. They can't control it anymore. And phase 4, they demonstrate dependence with periods of blackout, paranoia, and helplessness. So know those phases, and it's there on page 230, a nice little figure there. Know what blackout is. Prescription drug abuse is also something to be considered and is one of the fastest growing drug problems we have, of course, with the opioid crisis as well. I think somebody's doing a paper on the opioid crisis and the use of Narcan. I am trying to figure out if I can get information on how to give you a class on Narcan remotely. Well, I'm working on that, so hopefully we can get that done. Look at table 15.1, the warning signs of substance dependency, and then substance classifications recognized by the DSM-5. And then classifications of drugs that may cause substance-related disorders. And then other toxins and chemical substances that can cause a problem with people. All of those are on page 231, so get to know those. And then it talks about, some of the things that may cause substance use and disorder. Genetics and family influences. If you have parents who are alcoholics, is it genetic or is it because you saw that's how they coped with stress? There's a big overlap in discussion on whether or not it's genetic or maybe family influence. Peer pressure, environmental stress, chronic physiologic disease, and personality characteristics. Some people will just have more of an addictive type personality, so wanting to conform and blend in. Codependence is another topic on page 233. Know what a codependent is, know what enabling is. Those are definitions you're going to have to define on your paper today. Know what substance intoxication are and signs and symptoms of somebody who is intoxicated. That's important to know because if you're working in an ER or an urgent care center or many places, you may need to know what signs and symptoms of intoxication looks like. And know what happens when withdrawal occurs. Now, it depends on the substance, and we're going to talk about some specific substances. Your book has a nice chart, and I used to have students look up and do a little group project in class on these, but you have a chart starting on page 235, and it goes clear over through 240 on the different types of substances. I'm going to go over briefly a couple things, but I don't have time on this video to go through all of them. Just know you're going to need to understand alcohol and what it does to the body. That this is one of the most common substances that is abused in the United States. You probably know or have seen somebody who's gotten drunk, but having somebody who has an alcohol problem, oftentimes they try to hide their drinking. Know what the chronic use of alcohol can result in encephalopathy and psychosis and a condition called Wernicke-Korsakoff syndrome, which is basically a nutritional disease because there is a thiamine and niacin deficiency as a result of the alcoholism. And it's basically a dementia type situation. So we can avoid having the Wernicke-Korsakoff syndrome if we provide some nutritional supplements for people who have an alcohol problem. Alcohol detox is one of the most dangerous detox there is, of any substances. More people die from detoxing from alcohol than any other substance. Now, I know a lot of people die from opioids, but that's more from an overdose. When I'm talking about withdrawing from a substance, alcohol withdrawal is very dangerous. They can develop what we call the DTs, delirium tremens. And it basically says the delirium may last 72 to 80 hours, and there's a 5 to 15% fatality rate with that. So we need to be monitoring people, and we need people to be truthful with us on the substances they're using so that we can provide the appropriate medications to avoid fatalities. Withdrawal from alcohol can cause anxiety, tremors, seizures, hallucinations. Almost every body system is affected and may result in liver failure, heart enlargement, cancer, specifically the pancreas, the stomach, and the esophagus. And then it goes in and talks about cannabis use disorder, hallucinogen disorder. I want you to read through all of those. You need to understand what some of the substances are that people use. It even goes in talking about inhalant-related disorders and interventions for a person who's inhaling or huffing, and opioid use disorder, caffeine, nicotine, and sedative. I don't have time to go through all of those, but reading your chart is very helpful. And then it gets into substance abuse by healthcare professionals. We have high risk because we have a high stress job and we have access to substances. So make sure that you are being cautious and taking care of yourself, doing self-care, and not allowing yourself to be sucked into a substance use issue when you are in out of nursing school or working your career. I'm going to have you do a little activity about healthcare impairment, a healthcare person with impairment. And then understand what some of the different types of treatment there are for substance use disorders, and that is starting on page 251. Some of the interventions you want to think about, the vitamin therapy for the Wernicke-Korsakoff syndrome. Alcohol has a medication that we called Antabuse that we can give that if they ingest alcohol while on that medication, it makes them feel very, very sick and makes them not want to drink after that. Opioid withdrawal symptoms can be minimized with clonidine. Methadone oftentimes is used to help deal with some of the opioid withdrawal maintenance. There's another longer acting drug called Orlam, or LAAM, which is taken 3 times a week. So you probably heard of Suboxone. So get to know some of those other types of medications that we use. Read over your book. Hopefully this was helpful. I will try and do a Zoom today sometime so that we can have a question and answer time if you have any questions about the lesson. Have a good day. It's interesting stuff, guys. Thanks.